It is very cool to be here. My name is Brian Jacob, and I have a very important story to tell you about a memorable patient of mine who came in with groin pain. And in the next 10 minutes, I'm going to teach you how you can become part of her solution. But before I do, I want you all to take 2 seconds and just close your eyes, if you would. And I want you to think back to the last time or the last groin pain patient that came into your office. Was it last week? Last month? Do you have that visual? What did that patient look like? Were they crying? How many surgeons had they seen before they were sitting there? How are you going to establish rapport with a patient that looks like that? Because establishing rapport is the very most important thing that you can do before you're going to treat a patient. The problem is they don't teach you in residency in school how to establish rapport. Eye contact, getting at the same level as the patient. Earning that trust is really, really important. But there's something unique about groin pain patients, and that is sometimes they first want to establish rapport with you, not the other way around. And thus begins my story. Now, my patient, let's call her name Jane, sent me a letter. I happen to have Jane's letter here. And I want to share with you this letter because it really changed my life. Dear Dr. Jacob, before I meet you, I want to share my story. As you heard, I had expressed losing a will to live. Copy of the letter. This is due to the 18 months of agonizing pain that I have been in. I am on antidepressants, I'm talking to someone, but the pain has taken over my existence. And I'll never forget this next line. As of November 22nd, 2015, right, not that long ago, I was a perfectly healthy, thin, fit, youthful, strong, smart, funny woman without pain. The following day, I had my first hernia repair. Now, not many letters start out like that, but she had my attention. From the moment I left the hospital, I spent 8 months in agonizing severe pain. Doctors had no idea what was going on. 8 months after my first surgery, I finally had what they said was all my mesh and tacks removed. But in her own words, she continues, things spiraled out of control. Not a day went by where the pain didn't start to spread and it became bloated and vomiting, and the pain continued to get worse. She was sent to pain management. She ended up addicted to narcotics. The letter continues. I cannot walk without aggravating the hernia, and the abdominal pain is often unbearable. I had nerve blocks without relief. My life is agonizing in so many ways. She then finishes the letter at the bottom. No one can figure this out. I am so desperate for just one day without suffering. If you have any knowledge of where to go from here, I beg you to help. What do? You have a letter like that on your desk. Do you call your friend and send them there? I picked up the phone and I called her. I said, let's get her in and see what her story is. So Jane comes into the office. And she's sitting there and she's rocking back and forth and she's crying and her hands are shaky. She tells me her story, and the first thing you do is you get op reports. And the operation that she had, which was a routine surgery, and she was an active tennis player at a country club, no pain, had lots of friends. And the first surgery she had, you read the op report, you could tell it wasn't routine. It was a laparoscopic tap, but they used 3 pieces of mesh, 3 different tackers, metal tacks, absorber tacks, a hernia stapler. There was a split in the mesh around the round ligament. It just didn't sound routine to me. And when you read it And then you say, okay, she woke up in agonizing pain. You say, well, why didn't they go back right away? Instead, sent on for pain medication. The second surgery was an explantation of that mesh and the tax. And of course, when you take out mesh, for those that do, you end up taking out the transversalis muscle. And they put in a biologic to try to compensate for that bulge. And that was also done with a TAPP technique. The problem is, she also was addicted to narcotics. Now, when I get patients in the office with this problem, I do something called pain mapping. All right? Now, pain mapping is a way to take that complaint and turn it into something that you can put into the medical record and also help you distinguish between something called nociceptive pain, which is point tenderness, like the thorn in the lion's foot, or neuropathic pain, which is triggered burning sensation along a nerve. And unless you pain map your patients and draw on their belly and take a picture and put it in the chart, you really can't help them figure out their problem. So this is Jane's pain mapping. First time she came in, and you can see I always draw the ASIS, or the anterior superior iliac crest, and that way I can correlate imaging to where the pain location really is. And she had nociceptive pain in the right lower quadrant, and she had bloating suprapubically, and then she had a little bit of other pain up near the umbilicus. Not one surgeon in the last 8 months got an image on this. Anyone else would get an image here? Now, CT scan red is normal, but you're going to see the problem if you pay attention. Anyone see that? Did you catch it? You shouldn't see bowel between the bladder and the rectus muscle. And if you see bowel between the bladder and the rectus muscle, and you have a patient with bloating, and you have pain in that area, something's up. Now again, CT scan report, which most people realize is what they read, said no obstruction, no hernia. Why is there no hernia? She's laying flat. So a lot of times the hernias aren't seen. So I said to Jane, I want to take a look with a laparoscope and see if what I can find is going to correlate and get you out of that bloaty pain. I may not cure you, but I need to give you some guidance towards getting you better. We had one problem with Jane. 8 of these a day. Shaky. So I said, you know what, we have to get you off of the Percocets first before I'm going to operate on you because I can't tell where the pain is. And so I made her come back, and the second time she came back with her daughter, and the daughter said she's not just on Percocet, she does other things, and we don't really know. She came back with a friend on a third visit, and each time she was much more sober. And by the last visit that I had her, she was completely narcotic-free. And I saw Jane for the first time with a smile. No shaking, no tears, and she was psyched for this surgery to see if the two things correlated. Really, really excited. And so like everybody else, she finally gets on the schedule. For us, it was on a Monday, and on Friday, we called the patients to tell them the time. So she had a 2 o'clock time slot, and the office tried to call her, and she didn't answer the phone. I had come into the office. I was doing work at the desk, and my Jen comes into the office and says, I can't reach her. I said, call the daughter because she always answers the phone. Disappears, I'm doing work. Jen comes back. Dr. Jacob, I got in touch with the daughter. Jane never made it to surgery on Monday. Jane took her life Thursday night, alone in a hotel room during a relapse for taking her narcotics. She killed herself from an overdose. I remember the last line of the letter. I'm so desperate for just one day without suffering. And let me tell you something. I was pissed. Pissed off because there was a groin pain patient that 3 surgeons had turfed to pain management that became addicted to narcotics that didn't catch it, and it led, directly or indirectly, to a death. And these surgeons had no idea. A few days go by, I unwind, I told some friends about it. I had the letter, and I said, I need to do something more. Did Jane die alone? Was this an isolated event, or did Jane die as part of a bigger problem? And it turns out, as some of you in the room know, that she definitely died as part of a bigger problem. Inguinal hernia pain after surgery occurs in what percent? 6. 6% of patients have chronic pain. And I know there's not one surgeon in this room that thinks that that's their outcome, but this is a true statement and a dialogue starter. 500,000 surgeries a year, you've got 30,000 groin pain patients out there. That's just in the USA. Now let's take this a step further. In 2017 in JAMA, there's a great paper by Chad Brummett, and they looked at all comers in a population of 31,000 who came in for elective surgery previously not on pain medicine. Pain medicine was prescribed for post-op pain, and in those patients, 6% were still taking narcotics 6 months later. 6%. Now, if we take that 6% and blend it to that 30,000, we have 1,800 new narcotic users from inguinal hernia repairs in the United States. And the number may be around there, it may be a little bit less, but that's a lot of people. In 2016, the National Center for Health Statistics put out a number that 116 people die every day from opioid-related drug overdoses. And the next number is staggering to me, but 17,000 deaths were attributed to overdosing on commonly prescribed opioids, the stuff that we write every day. Jane did not die alone that day. 115 other people did also. So the next question is, what can we do to help become part of that solution? Mike Reinhorn's a surgeon in private practice in Boston, and he looked at his practice of hernia patients. He published last year, he had done 185 of them, and 160, he analyzed them, only took 0 to 4 tablets of Percocet. And his conclusion was, that's it, I'm done writing Percocet for my inguinal hernia cases. Advil and Tylenol for them. And if he did write them, he'd write for 5 tablets. And I said, that's amazing. That's how you start becoming part of the solution. Tonya Young-Faddock knows it's a bigger problem, not just from hernia. Fellow board member at SAGES started a task force with a mission to reduce and if not completely alleviate the use of narcotics after surgery, including colon surgeries. She's becoming part of the solution. My mission is to decrease both of those 6%. The 6% addicts we can help by not prescribing narcotics after inguinal hernia repairs. And the other 6% that have chronic pain, we can help by listening to them, by establishing rapport and not turfing them to pain medicine doctors who don't know how to treat pain that we caused. I had a patient 3 months ago wake up with severe pain after my surgery, and I took her back on day 4, and I took out the insulting device, and she got better. I didn't send her anywhere. I owned up and I took care of it. We have to listen to these groin pain patients and examine their backs and examine their hips and examine their groins and their legs and their abdomens and their pubic bones and not just operate on hernias because they have one. If you're a plug and patch user or if you're a PHS user, get your patients involved in the dialogue before you implant that device so that they understand what's in them, because at some point if they have chronic pain, there's a few of us out there that are taking these things out weekly. That's how I'm contributing to the solution. Join me in becoming part of the solution instead of contributing to the problem. The next time you have a groin pain patient come into your office, close your eyes, but this time think of Jane. Thank you. All right, I'll take them both. Deserves it.
I think that talk is worth 2 beers, Ryan.
Thanks.
Wow. Thank you very much for sharing Jane's story. Jane is a pseudonym. I happen to know that. And there's a reason why we had Brian come up last, because nobody should follow a story like that.
I have a question.
Yeah.
So one of the groin pain issues is, do you cut the ilioinguinal nerve or do you preserve it? And that some of the open hernia pain is felt to be nerve entrapment, nerve damage, and so forth. That's probably one of the more common scenarios. So what's your advice for that?
So there's two answers to that. One is literature-driven, one is my own personal opinion. Pragmatic neurectomy is because you're doing an open Lichtenstein, you find a big ilioinguinal nerve. If you see it and you think in your head that there's going to be a chance that that's going to get incorporated into scar tissue, you have my permission to take it out. I do it pretty much regularly with my open Lichtensteins, but there's not been shown to be a great correlation to that preventing pain. The nerve anatomy in the groin is so random and unlike the Netter textbook that even if you take out one, there are branches of other ones nearby. Interestingly enough, most of the pain that comes in after these operations, though, is nociceptive, with the occasional neuropathic pain in that area. But I take it out right away.
And have you found that when they do have pain, it doesn't show up for months and months? Because as the groin kind of scars in, that nerve that was sort of flopping out there gets wrapped up into the scar tissue, different than what you described, somebody wakes up and has pain.
1 to 2 weeks is when that pain shows up. So as the scar tissue forms, the patients will start complaining of pain under the incision, mostly when they start to exercise and cross their legs, because remember, that's where it moves. You know, it's really interesting. If you put a laparoscope in to the groin, and you take your patient's leg, and I'm going to show you something here, but try this next week when you go home. Put the laparoscope in, take your patient's leg, and move it around. When you look at the inside, it doesn't move at all. It's a soup ball. So when you move that leg, there's no movement of that posteriorly placed mesh, or very little of it. So if they have tremendous amount of movement or posterior repair, it's probably not your mesh, at least if it's nociceptive, not from movement.
How many people in the audience take the ilioinguinal nerve during an open Lichtenstein procedure? Some, maybe 20%. I do in the older patients, and think about trying to preserve it in the younger patients because they don't notice.
Some of the more difficult cases I've had are, some of the more difficult ones I've had have been after TAPS or from lap hernias, and we call it surgical shrapnel when you see a KUB and it's got a bunch of tacks all over the place. So I've certainly teach my fellows never to put tacks lateral to the epigastric vessels. Have you been able to have cases where you've been able to identify the tack and take the tack out, the offending tack?
I love those cases, and that's why I hope people don't stop using metal tacks, because you can find them with fluoroscopy, and you can draw on the belly and correlate it. Now, the problem is when you go in thinking it's the tack, but the pain is not directly over where your fluoro shows the tack is, and you can know right then and there that the pain's not going to go away even after you take out the tack. It's from something different. But there's the hope that you can. You know, we like those cases.
We have a question from the floor.
Sean Ornstein, Portland. Brian, thank you for that wonderful and powerful talk on a pretty tough topic. And I got to be honest with you, when I see a groin pain on my clinic schedule, I cringe. I schedule these patients for the last patient of the day and schedule them for a solid hour because I know it's more than a 15, 20-minute visit. My question for you is, at what point do you offer surgical intervention for these patients? I've seen great talks from you, from David Shen, about sort of a stepwise algorithm of diagnosing and treating groin pain. But at some point, a lot of these patients may or maybe not benefit from surgery. So from your perspective, when do you decide, yeah, you know what, it's time to take them to the OR and look around and do something maybe?
So
Thanks.
I try to avoid algorithms with these patients and focus very much so on their history. And I ask a lot of questions. So an office visit for groin pain is 30 minutes of discussion and 3 minutes examining. And my examination, the entirety of it, is drawing on their belly and figuring out where the pain is, and then doing the back, the hip, the rectus muscle, the legs, and the pubic bone. And then if there is a surgical maneuver that I think will alleviate what I just found, I will offer surgery. I don't think you have to exhaust injections for nociceptive pain when the story fits something that you're going to go in and find. And those things can be a plug, they can be a fascial tear of the nerve coming through it, it could be a suture granuloma. There are a lot of things that cause very severe pain to patients. that you can fix with an operation. So to answer your question briefly, I don't follow algorithms. I listen to their history.
And is there such a thing as meshalgia?
What do you mean by mesalgia?
People are convinced their pain is coming from the mesh, and they're begging you to take the mesh out, sort of vague symptoms. And I always wonder, when I take the mesh out, what am I going to put in?
So foreign body reaction, or FBR, is a real issue. And there are patients who have sensitivities to polypropylene and polyester. It's extremely rare, but there are systemic reactions to mesh in very rare patients. What is also true, though, remember, patients don't have a clue what's causing pain. So Jane definitely had pain from her recurrent hernia, but she also had pain from bowel being stuck between the bladder and the anterior abdominal wall. But in her brain, it was all one thing, but there were more than one entity going on. So you have to tease the two apart, for sure. The patients who have foreign body reaction who you're not going to cure, you definitely need to work with them, but also tell them about post-traumatic stress disorder. So PTSD is a serious entity that goes along with a lot of these patients, and you tell them you're not going to cure the PTSD. These patients have oftentimes been struggling with pain that people have been telling them is not from the mesh for 8 years, for 10 years. 20 years. And so when you finally remove the insulting device, that concern, the anxiety that came with it is not going away, not for several years. So you have to remind them that there's going to be a systemic anxiety-induced response that's going to live past you removing it. And that, you talk about patience from the other talks, it's years of patience with them, because they're going to come back and tell you didn't fix them. You did, but you got to push them, push them, push them.
So we'd like to really thank you for your story. Please, this is a project. Brian Duncan, who's in Australia, is our third partner in crime. If you like this format, tell us. If you hate this format, tell us. It's a little different than the usual podiums, but feedback is a gift, and I'd like to thank all the speakers.
Here, I think if you ever get a chance to do one of these yourself, you'll find it's a little more work than the PowerPoint slide. So I would like to thank Bob, Julie, and Brian for all the work they put in. Really great job, guys. Thank you.
Thank you very much.